Hello, everyone, and welcome to today's webinar for mental health professionals, spirituality, and mental health, what clinicians need to know, featuring David Rosmarin. My name is Astrid Masfar, and I'm the Professional Education Manager at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's webinar. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You have joined the presentation listening using your computer speaker system by default. If you prefer to join over the telephone, just select telephone in the audio panel and the dial-in information will be displayed. Please make sure you're muted during the entire presentation and your webcam is disabled. You will have the opportunity to submit any questions by typing them into the chat box located on the control panel. You may send in your questions at any time and we will address them during the Q&A session at the end. If you have registered and paid for CE credit, you will need to provide 4-letter CE code in the webinar evaluation. The CE code will be shared at the end of the presentation and the link to the evaluation will be sent to each participant within 48 hours of this webinar. The post-test assessment will occur at the end of the presentation. The questions will appear on your screen and you will be given 5 minutes to complete the assessment. Once complete, please click Submit. I would now like to introduce today's presenter, Dr. David Rosmarin. Dr. Rosmarin is a director of the Spirituality and Mental Health Program at McLean Hospital and an assistant professor at the Department of Psychiatry at Harvard Medical School. He supervises the provision of spirituality integrated services and clinical units throughout McLean Hospital's divisional structure and collaborates with laboratories to study the clinical relevance of spirituality to anxiety, mood, psychotic, substance use, and other disorders. I will now pass the screen to our presenter.
Good afternoon, everyone, and thanks for joining. I'm very grateful to the Anxiety and Depression Association of America for inviting me to give a talk on spirituality and mental health, what clinicians need to know. And I'm grateful to all of you for being here. I'm also grateful to the many people who I've worked with over the years. This is a short list of literally 250 people. I did count once and got to 250. Mentors, collaborators, colleagues, students, family members, and funding support, of course. And I don't have any conflicts of interest to disclose. So by way of introducing the topic, this is a case that I assisted with as a consultant at McLean Hospital. And what that means is that as a psychologist who specializes in spiritual and religious issues, and no, I'm not clergy, in case you were wondering, I was called in to deal with this. And we'll call this patient Elizabeth Carmen, 27-year-old female, Roman Catholic background. She had suffered from a severe anxiety disorder for the better part of her life, and probably 20 years plus. And eventually she experienced chronic pain, ended up abusing opiates to deal with both her pain and her anxiety. And by the time she came to our hospital, her substance abuse had gotten to the point that she needed intensive detoxification. And it was definitely going to be a long road. And after, I think it was 5 days of detox, fairly long time, she entered a partial hospital where she would come at 9 a.m. and leave at 3 p.m. every day and go to intensive groups and other treatments specifically for anxiety. We have a very cognitive and dialectical behavior therapy based partial at McLean. She was doing well in the treatment, but she was very reserved. She really wasn't showing a lot of emotion. She wasn't engaging in a lot of emotional experience or allowing herself to feel anxious or anything. And then one day on the unit, during the lunchtime in the milieu, one of the nurses overheard her having a very passionate conversation with a fellow patient. And she started crying and having a lot of emotion and saying, "God hates me, God hates me." And the nurse went over to her and said, "Would you like to speak about that? Is that something you'd like to talk about with your treatment team?" And she said, "No way. I'm not talking to you about my spiritual life. If I do, you're just going to throw me in the psychotic ward." And that was when they called me up. In another case, I'm going to introduce you to Mike Johnson. We'll call this patient. This is a devout Christian man who's a successful CEO. He came to one of our programs, which is typically a 2-week program, and he really did not fare well. So he extended his stay. His background was very severe depression. Previously, he had a very active lifestyle, very successful company, like I mentioned, and he had a series of medical setbacks. It made it impossible for him to stay at the helm of his business and also to continue to be active in terms of his sports and other things that he did. He gained 100 pounds. He had significant health decline. He gained more weight, had developed a pain disorder, and then started to become hopelessly depressed. There were only 2 things going well for him, and his clinical team knew this. His family was going well, and his spiritual life. He was a man of faith, but given the severity of his depression, he really couldn't access these. And his clinical team was wondering, like, with his family, we can involve them in treatment and we can help him to re-engage with them. But with his spiritual life, is that our role? Is that the kind of thing that we should address? Should we be helping him to access it? Does it go beyond the pale of what we do? And I was called in for a consultant there too. And I'll round out these 2 cases later. It's not inconsequential that for these types of patients and for many, many others, that they're either uncomfortable addressing spiritual issues with us as clinicians, or clinical teams are not capable or comfortable addressing spiritual life. And the reason why it's not inconsequential is because spiritual and religious life, at least in the United States, are extremely common. Many of my colleagues are shocked when I present these kinds of stats, such as nearly 2/3 of the country is certain that God exists. That'd be the top anchor on a 4-point scale. More than 3/4 are religiously affiliated. More than 90% have some level of belief in God, and that's not God or a higher power, that's God. More than half praying once a day. Now, people often say to me, well, this is inflated by the Bible Belt. And it's true that in Mississippi, you will find 80% of individuals in church on a Sunday morning. But even in the least religious enclaves of the United States, such as Massachusetts, where I live, or New Hampshire, you still find 30, 40+% of the population going to services. Here in Massachusetts, 37% of the population prays daily, and a full and 55% are going to religious services on a regular basis. And 67% of Massachusetts residents have a religious affiliation. Now, not only is it common in the general population, spiritual and religious life is common among psychiatric patients. These are stats from a study that I did with McLean Hospital patients. And McLean's in the eastern part of Massachusetts, not exactly the most religious area of the country, not exactly the Bible Belt. And as you can see, 81% of patients praying on a weekly basis. This is something that's not only common, but almost central. I mean, these are already, I think, at the level of identity. Now, perhaps for these reasons, most patients, and I say that in the statistical sense, that more than half of patients want to discuss spiritual religious issues with their clinical teams. A number of years ago, the first row on the screen, 58.2%, those are the number of patients that we found at McLean. When I was doing that study with my colleagues, I estimated 25% maybe of our patients would want to have a discussion about spiritual or religious issues with their treatment teams. My colleagues who I did the study with thought it would be 10 to 15%. Across the board, though, even if it's 10 to 15%, it still behooves us to get competent in this area, to be able to address it, like we would any other. But all of us were wrong. It was 58 0.2%, more than half of our patients. When I presented that data, a lot of my colleagues said, oh, well, isn't it just the psychotic patients who want it? And isn't it just the manic patients? And maybe it's the folks with OCD. So I checked, I did a logistical regression, and none of those appeared to be predictors. None of those were predictors of interest in spiritually integrated treatment. The only predictor clinically was patients who were currently depressed. Patients who were currently depressed wanted more, were more likely, slightly more likely, to want to discuss spiritual issues with clinicians. Why? I don't know. Maybe they are looking for hope, meaning, purpose, connection in a spiritual sense, and that becomes part of the discussion for them. But that's further research is required on that one. What was also really interesting was that we looked at religious affiliation as a predictor of people's interest. And what we found is that many affiliated patients, in fact, nearly 40%, had low or no interest in speaking to clinicians about spiritual issues. And conversely, many patients who had no religious affiliation, 37% of unaffiliated patients, people who had no religious affiliation, still wanted to discuss spiritual and religious issues with their clinicians. And what that indicates, and we'll get to this later, is that the current practice of asking a patient, is there a religion that you affiliate with, doesn't tell us very much. It doesn't tell us whether the patient wants to discuss it with us, how it's relevant to their treatment, and it doesn't tell us where to go. It might be an interesting demographic, but it's not clinically relevant as asking them, do they want to discuss it with us? In any event, we're not the only place that has found this. In other locales as well, similarly more than half. And furthermore, if you look at the number of individuals who seek mental health in churches as opposed to by mental health professionals, it's substantially more. But we struggle with this as clinicians. My favorite is the bottom row on this slide, where nearly 10% of psychiatrists will tactfully change the subject of spirituality when a patient raises it. But even in the psychology world, which I'm from, still most people are not comfortable with this. They rarely discuss it. They're not, this isn't the kind of area that we get training in. And I think that's why at this point we don't really have a lexicon to be able to discuss this with patients. We don't have the conceptual framework, and that's why we're doing this webinar. Another important thing is that in the mental health world, people tend to have more negative attitudes towards this domain compared to other areas of healthcare. The captions here are pretty small on the slide, but psychiatrists are more likely to endorse that spirituality and religion causes guilt, anxiety, and other negative emotions compared to other clinicians. Just to give you the numbers, for psychiatrists, 19% will say that spiritual or religious life often or always causes guilt, anxiety, or other negative emotions, 19%. With other physicians, it's still common to have that, but it's 7%, which is less than half. In another study and the sources down there, I'm sorry, actually in a separate study written by the same authors, by Farr Curlin, who's at University of Chicago, paper published in Psychiatric Services in 2007, psychiatrists were found to be less significantly spiritual and religious than all other physicians, even surgeons. So the number of people, for example, having no religious affiliation was nearly double among psychiatrists versus other clinicians. Now, our discomfort with spiritual and religious life occurs in a historical context. And there's no one more notable than Sigmund Freud for his anti-religious views. In fact, if memory serves correctly, this was one of the primary departure points between him and Carl Jung, which eventually led to them parting ways. Just a bit of historical note over there. These are two excerpts from his writings, and you can see his incredible ability to express himself, especially in the second one. His language just very rich, but at the same time very antagonistic. the notion that spirituality and religion is humiliating, and it's it's a terrible thing that people have it today. You know, at this point in time, we don't have such outright antagonism towards spirituality and religion, at least not openly. If we did, then I wouldn't have a job, so I'm grateful for that. But what we do have is this notion that spirituality and religion should be checked at the door of the therapy room, that it doesn't have a place. And many people will say, even if it does have a place, it's not a priority, it's not important to discuss or to get training on. There are other more pressing areas to be able to focus on. I think it's a mistake. I'll just tell you a quick story. Many years ago, before coming to McLean, I was on an interview for a clinical placement, and the interview was going really well. It was for a cognitive behavior therapy clinic, so I could learn about anxiety disorders. And I had just the right amount of training that I wouldn't be a burden to the clinic, but not enough that it would be a redundant training experience. So the conversation was going great. And then 20 minutes or so in, the director turned to me and said, I see that you're doing work on spiritual and religious life, and that you visibly identify as somebody who has faith. If you come to this clinic and train here, you're not going to speak to our patients about spirituality, are you? That's not the kind of thing that we do. So I remember being really torn, because what if the patients wanted to speak to me about it, and what if that was relevant to the clinical picture? But I didn't push back. I was on interview. It wasn't my place or the time. So I said the only thing that I could say, which was, if those are the policies of your clinic, then I'll abide by that and any other policies of your clinic. And I remember I was there for quite a while, and at least 3 or 4 patients wanted to speak to me about spiritual life. I guess I'm a cue for it. And I said, I'm really sorry. That's not the kind of thing we do here, but is there someone else you can speak to? And I don't think it was it was beneficial. I think it was to their detriment, actually. Before going further, I think it's important to define some terms: spirituality and then religion. I find that clinicians are more sensitive to this than patients. Patients don't usually care very much, frankly. They just want to be helped. But clinicians, rightfully, are often very thoughtful and graduate school educated and want to, understand what we're talking about. So I find that if I don't define these terms, then, they almost always comes up during Q&A. So what is spirituality? A psychological definition, which I've taken from my graduate school mentor, Kenneth Pargament, and his colleagues, is that it's a broad term, and it refers to any way at all of relating to that which is regarded as sacred. Sacred is the only operative word in that definition. And what that means, sacred means specifically sanctified, holy, consecrated, which the literal definition is actually separate or set apart from the physical world. Something which is not material, something which is greater than that. So spirituality is sacred, but it can be secular in that it doesn't have to be religious. If people have a spiritual experience walking in the park, while walking through a forest, having conversations with a friend, and they feel very connected to them, not only in the present sense interpersonally, but in a sacred way, something which is holy or consecrated or greater than that, that could be a spiritual experience, even though it doesn't necessarily occur in a religious, historical, institutionalized context. Religion, by contrast, is a subset of spirituality, in that it's a culture-bound, institutionalized ways of defining the sacred and relating to it. So the only difference is really if something is established in an established culture or institution, and it's sacred, that would be religion. And if it's not, then it's spirituality. If you're going to put it on a Venn diagram, this is what it would look like. This isn't to scale, but the religion oval is taking up a lot of the spirituality. And the reason for that is because in the United States anyway, spirituality and religion have a lot of overlap. Here, the concordance rates are between 59 and 74%. And what that means is that the vast majority of Americans are either spiritual and religious or neither. There are a growing number of people who identify as spiritual but not religious, but it's still very much the minority, about between 5 and 11% of our population, and then the remainder are neither. In the interest of parsimony, in this presentation and really in all of my writings, I conflate spirituality and religion because the concordance rates are high and because most people don't care. But if you're a linguist or like a religious philosopher and you take exception, then please pardon me and please forgive me. I'm happy to have a discussion with you further. Okay, with those definitions in mind and with the background of spirituality being common and subjectively relevant to patients in their care, how is spirituality relevant to mental health? Well, there are 3 ways. First, many individuals have rich spiritual resources that either can help them to cope with mental health disorders when they have them, or they can prevent those disorders from occurring in the first place. There are 3 consistent effects in the literature that we've found, and I say consistent being hundreds of studies, tens or hundreds of thousands of participants. And there are other areas of the literature aside from these 3, but those areas are less established, and I'm not fully confident about them. Hopefully, over time, we'll be able to be more decisive about it. But these 3 are clear, at least to me. The first is with depression. There have been over 500 quantitative studies looking at spiritual and religious life broadly defined, whether it's beliefs or practices, and depression. And the overwhelming majority of those studies find inverse correlations, that the more spiritual and religious a person is, the less depression. The effect sizes, however, are fairly small. Often 2% of the variance, 5% of the variance. I've seen 10, but it's not huge amounts of protective effect. With that said, there is some data that for high-risk populations, when individuals are the descendants of depressed parents, for example, that the more they're involved in religion and spirituality, the more protected they are from depression. Another effect is on suicide. Some of my colleagues at the Harvard School of Public Health, Tyler Vanderweel and colleagues, recently published a study based on the American Nurses study of 90,000 American women, finding that religious service attendance on a weekly basis was associated with a 5-fold decrease in suicide compared to no attendance at all. So that already is pretty substantial. Another body of research or findings on substance abuse, that a lot of data showing spirituality and religion protecting against incidence and also severity of alcohol and substance use disorders. And there the effects are pretty large, and same with suicide compared to depression. There are a couple of potential reasons for these effects. For depression in particular, spiritual and religious life can convey themes of hope, meaning, purpose in life. They can convey positive emotions like gratitude. They can keep people hopeful. A couple years ago at McLean, we found that that patients who had greater belief in God had greater reductions in depression, reductions in self-harm, and increases in psychological well-being while coming to an intensive treatment program. What was interesting, though, is that those effects, especially for depression, were mediated by greater belief in treatment, by greater treatment credibility and expectancies, which means that individuals who, to the extent that faith predicted better treatment outcomes, that was accounted for by greater faith, not in God, but in treatment. So that's potentially an explanation. Another explanation is called religious coping. If you do a Google Scholar search on religious coping, you'll be amazed what you find. Over 5,000 empirical articles showing that individuals use religion to cope with distress, and furthermore that there are effects of that can be helpful to individuals. There are a lot of ways that people use religion to cope with distress. One of them is cognitive benevolent religious appraisals, where people see their situation as a part of God's plan. They might say, this is terrible, but I know there's a greater plan for this. I know that it fits in somewhere, I just don't know what that is. Another one is active religious surrender, where people say, I'm going to do whatever I can, but the rest, I'm just going to give it up to God. It's not in my hands. And those can be adaptive cognitive schemas to reduce stress and to remain engaged. That last one, active religious surrender, is typified by the Serenity Prayer, which is very popular in 12-step programs and otherwise. Another explanation, though, is that spiritual and religious life, broadly defined, is associated with greater self-control. Dr. Michael McCullough, who has been at the University of Miami until recently, he has suggested that all of the observed effects of spirituality and religion on health, not just mental health, boil down to this self-control, that spirituality and religion can override prepotent cognitive, behavioral, and emotional responses or tendencies. In English, when people are engaging in regular spiritual practice, it can enhance self-control and buffer it against impulsivity. And one of the ways I like to explain this is that when a person prays, typically there's not a response right away. By the way, if anybody here knows how to pray and get a response immediately, please send me an email. I want to know your trick. But most people's prayer experience is that they are engaging something, and sometimes they feel that they connect, sometimes they feel that it works, and other times they feel that there's nothing there, but they'll engage in it anyway. So that's a good habituation in some ways to delayed gratification, to delayed reward, and potentially to enhancing self-control. These are some initial data. Actually, there's no stats on the slide, but this is a picture of the BART task, the balloon analog wrist task. And this is an experimental task where people are presented with a balloon worth 25 cents, and they press a space bar, and then it goes up to 50 cents, and they press it again, and it goes up to 75 cents. But with each press, there's a greater likelihood that the balloon will pop and they will lose their money. So greater pumps and greater bursts are a good indicator, a behavioral indicator, experimental behavioral indicator of greater impulsivity. And what we found briefly is that religious factors among adolescents are associated with less risk-taking, less impulsivity. And this could explain the effects on suicidality and also on substance use. Because if it's a buffer against impulsivity and enhances self-control, then that could be a reason. For whatever the reason, we do find protective effects, spiritual resources. However, I would be lying to you if I told you that spirituality was all fun and games, because it sure isn't. But anything in life can be positive or can also be negative. So it's no surprise, really, that spirituality can be a tremendous burden and a source of strain and distress for many people. We call these negative effects spiritual struggles. Sometimes in the literature, though, they're referred to as negative religious coping. Spiritual struggles are beliefs, emotions, and behaviors from a spiritual and religious context that exacerbate and potentially even play an ideological causal role in the development of emotional distress. Empirically speaking, spiritual struggles are less common in the general population than positive forms of spirituality. Positive forms of spiritual and religious life are endorsed in many studies by 80%, 70% plus of the population. The negative side are usually endorsed by 10 to 20% of the population in larger studies. However, when they occur, they can exert very large and clinically significant effects on psychological distress. Furthermore, I have found that they are more likely to occur, substantially more likely to occur in patient populations. When patients come in, it's not just 20% who are having spiritual struggles, often it's 50% or more. There are three types of spiritual struggles. The first are inner struggles, inner spiritual struggles. In a nutshell, a lot of people look inside of themselves and they don't like what they see. They might be wrestling with their religious identity. What's my spiritual purpose in life? Do I have a purpose in life? Is there anything that I'm really here to do? Is there something greater? And struggling with that. I don't just mean asking those questions. That can be very helpful. I mean struggling with it to the point of emotional distress. Sometimes people struggle to control themselves. They engage in certain behaviors that they're embarrassed of or ashamed of, and they have a sense of religious guilt or shame for having done certain things. And sometimes that guilt and shame overshadows everything in a person's life, or enough that it makes it very difficult for them to function. Sometimes people have fatalistic beliefs that they are tainted and they cannot overcome something that they've done or something who they are, or it's a part of themselves. And these are clearly occur, and when they do, there are effects. A second type of struggle, spiritual struggle, are interpersonal struggles. Interpersonal spiritual struggles have social or relationship issues that occur within spiritual or religious life. The most common examples are disagreeing with clergy, and I don't just mean disagreeing, but fallouts, altercations with others within a spiritual community, or having witnessed or being harmed by religious individuals. One of my patients put it this way. They said, I really don't like fighting with people at work because it makes me tense. But when I have an argument with someone at my church, I lose my horizontal relationships and also my vertical relationships. And these are, I think, particularly problematic. Every week at McLean Hospital, we provide spiritually integrated psychotherapy groups. That's one of the innovations I've made there. And every week, patients raise the subject of sexual abuse of minors within the Archdiocese of the Catholic Church. These kinds of things, interpersonal spiritual struggles, I think they have greater staying power in the memory than secular interpersonal struggles. It certainly seems to be that way, and there's some data to suggest it, although more research is necessary. The last, though, are divine spiritual struggles, and these involve questions between, not just questions, but struggles between human beings and what they perceive to be the divine. The most pervasive is the question of theodicy and why do bad things happen to good people? And no, I don't know the answer to that question. I don't just mean asking that question or I mean being stuck on it. When people are stuck on it and it gnaws at them to the point of distress, that's a spiritual struggle. Other issues are a punishing God appraisal, where people feel that they're being unjustly punished and they feel angry at God for that. They feel distressed by it, significant shame because of it, or demonic appraisals, where people feel that the devil is out to get them. These beliefs can taint day-to-day thinking and increase stress in very unique ways. Years ago, I saw a patient who, in her mid-20s, who came to my office with generalized anxiety disorder and depression. And earlier in her life, there was a family tragedy where a family member was driving and one of her nieces became a quadriplegic and was put on a respirator and a feeding tube. And my patient, she didn't have PTSD, but this event affected her and her thinking, because when I spoke to her about it, her perception of it was that it was a divine punishment, and it was exacted for a failure on her family's part to adhere to a set of moral standards. And I asked, well, what were the standards? What did you do? And she said, I don't know. And for that reason, throughout her day-to-day life, she was very careful to be very exacting on anything she could, because she didn't want the other shoe to drop. Daily hassles for her, such as driving in traffic, and she was from New York, so that happened a lot. Daily hassles were not just, okay, it's traffic. That's not how she perceived it. She perceived it as God punishing her for something that she had done at some point. And these pernicious beliefs were shaping her day-to-day life. And in fact, when we traced back all of her depressive episodes over the years, we identified that there were triggers specifically related. That way of thinking was connected to the onset and the maintenance of her depression. Spiritual struggles are also empirically, beyond the anecdotes, they're empirically linked to distress, especially among patients. This is some data from a group of patients who happen to be psychotic patients that I studied back in McLean a couple years ago. What's important here is that the negative religious coping, which is spiritual struggles on the y-axis, was associated with between 37 and 46% of the variance. That's an R-squared value, pretty high, of pre-treatment suicidal ideation among this group of patients. That's already very significant, clinically significant, not just statistically. In a paper that I'm working on now, these are preliminary results. 42 42 subjects, including 25 geriatric mood disordered patients and 19 controls. And here we examined the effects of spiritual struggles on neural activity at resting state. What we found is that spiritual struggles were associated with greater activity in the default mode network, the executive controlled network, and the salience network, and particularly for individuals with mood disorders. And for those who don't know, greater activity in those regions is a decent neural signature of anxiety and depression. Because when a person's at rest, we would want their brain to be at rest. And if they can't shut it off, so to speak, if there's blood flow during a resting state, if there's activity during a resting state, it's often an indication of worry, rumination, or those kinds of cognitive processes. In sum, spiritual struggles are real and they can have negative effects on mental health. The last area, the third area that spirituality can have an effect on mental health is known as spiritual symptoms. If you look at this picture, the person seems to be praying, but it's a little bit odd. He's in his clothing, he's kneeling in the water. Something seems bizarre, and I don't know the individual, but it sure looks more psychotic than religious to my naked eye. Now, this involves co-opting of when spirituality and religion co-opts emotional distress. The three most common areas are psychotic disorders, religiously or morally themed obsessive compulsive disorder, and hyperreligiosity, which occurs in mania. I've also seen it in eating disorders, though, where people have spiritual and religious thoughts and practices that actually, it's not just a spiritual struggle contributing to the eating disorder, it's actually part and parcel of it. This is often the first thing that mental health clinicians think about when it comes to spirituality and mental health, because it's so obvious when it happens, you can't really ignore it. However, many clinicians make a classic error of illusory correlation. I have seen nearly 30 studies on religion and OCD, and I've yet to see any compelling data that religion is associated with greater incidence or prevalence of obsessive compulsive disorder. In fact, even epidemiologically, if you look in religious versus non-religious countries, such as comparing, I don't know, Egypt to Norway, the incidence, severity of OCD is the exact same. However, in Egypt, where it's a religious culture, 80 to 90% of patients have religious OCD. And in Norway, it's 5 to 10% of patients having religious OCD. So what seems to be occurring is not that the religion or spirituality is a risk factor for this, and similar, by the way, similar data occurs by psychosis. So it doesn't seem to be that religion is a risk factor for these disorders, but when religious individuals have OCD, mania, psychosis, other disorders, those often take on those religious themes. And for these reasons, I like to tell my patients who have religious symptoms, if you weren't religious, you would still have psychosis, OCD, whatever it is, it would just be about a different theme. You might not be praying compulsively, you might be checking compulsively. So therefore, well, let's review. I've made 4 points essentially. 1, spirituality and religion is very common in the general population. It's more common than it is not. Number 2, most patients, in general, it's subjectively important to many psychotherapy patients. In fact, the majority of patients want to discuss this with their clinicians. Number 3, for historical reasons, we've shied away from the subject matter, and many don't assess for it, some change the subject. And number 4, that's really too bad, because there are clear areas that spirituality and religion interfaces. Not only is it subjectively relevant and common, but it is functionally relevant in many cases in positive ways and negative ways, and also in terms of shaping symptom presentation to mental health. Okay, as clinicians, what can we do about this? Well, here's what I'm doing about it. In 2015, with philanthropic support, McLean Hospital started a program called the Spirituality and Mental Health Program. And this is the first of its kind in any non-sectarian psychiatric hospital. And it's a multifaceted initiative involving research and education, training of clinicians, including today's webinar, and also clinical work, clinical innovation in order to meet the needs of McLean patients throughout the hospital. One of the innovations that we've created, and I've trained patients to, clinicians rather, to be able to do with patients, is a brief assessment procedure. And I'm happy to go through that now with you, so that way you have a clear path forward to begin to discuss this matter with your patients. I would add that the following recommendations, the recommendations I'm about to make, I believe they apply with all patients, whether or not they have raised the subject of spiritual or religious life, and whether or not they have a religious identity. As you'll see, if it's not relevant, then the process stops. But given the sheer prevalence of spirituality and religion and its clear potential relevance to mental health, I think we should all, as clinicians, need to be assessing for this domain of life with all patients across the board, just like we would for so many other areas. Here's an overview of the approach. Essentially, there are just two main steps. There's an orientation or informed consent process, and then there's a functional assessment. And the functional assessment assesses for the three things that we discussed. The orientation, well, when you do any intervention or assessment, the first step is informed consent. But here it's a little bit different. This is a sample of the questions on your screen that you could ask patients. The idea here is to make an overture to a patient, to open the subject for discussion and to gauge whether they would like to discuss it. You can ask that flat out. Would you like to discuss spirituality and religion with me? That's a fine opener. But there could be some other questions in order to get at that and to look at the patient and gauge behaviorally whether it's something they want to discuss. Is spirituality important in your life? Has it always been that way? What are some of your practices? But the main thing is to get an assent or consent from the patient. An important purpose here also is that many patients don't feel comfortable speaking about spiritual and religious life. They don't even know that they're allowed to speak about it with you as a clinician. So it's important to, I think, to put the patient at ease and also to get a little bit of initial information about the patient's spiritual life. The main part, just to go back, if a patient says, no, I don't want to discuss it with you, well, then that's the end of the intervention, just like it would be with anything. I might ask why, like, you're welcome to discuss it with me. Is it something that's relevant? I might not push, but encourage a little bit about that, just because, why not? But just so I would know. But beyond that, of course, if the patient doesn't want to discuss it, then that's the end of the discussion. Assuming they do want to discuss it, the question becomes, how is your spirituality relevant and related to your symptoms? This is a functional assessment question because it sparks a discussion about how the spirituality is clinically relevant to the work that you are doing as a clinician with the patient. Now, it's a very specific question. So many patients will answer this by just going off in a tangent about their spiritual history, their spiritual life, and what their hopes are and their beliefs and their ambitions and their behaviors. Sometimes they've never spoken about it with a clinician at all, and you're the first one. So they might open up about it, which is fine, but I would redirect those patients and say, oh, that's really interesting that you are praying on a daily basis. How do you think that shapes your depression? How do you think that's relevant to your panic disorder? You've come to me for those symptoms, and I want to know, does it help? Does it make it harder? Does it shape the way in which you have those symptoms? What's going on? And that's basically the functional assessment. The functional assessment focuses on the three areas that we spoke about: spiritual resources, spiritual struggles, and spiritual symptoms. And those are the ones that we are trying to identify. When a patient discusses or identifies spiritual resources, let's say they have beliefs that could help them, they have behaviors that they're engaging in, or that they used to engage in before they were depressed, that they want to, but now they're too depressed to do so. Let's say they have communities that could be a benefit to them. Well, I like to encourage them, just like I would anything that's a resource to a patient. I don't think there's anything wrong with encouraging patients to pray or to become more part of faith communities. It's not evangelism to do so. And the field is not so secular that that's an anathema to be able to promote it if it's the kind of thing that's functionally relevant to the clinical picture. Going back to Mike Johnson from the beginning of the presentation, I encouraged Mike to engage with his faith, to pick up spiritual and religious books. So you go on Amazon.com and ordered a ton while on the units, to highlight meaningful excerpts from those readings, to turn them into posters and put them on his room, and to read them and to look at them in order to uplift him, to reconnect with his pastor who he had been disconnected from for a long time, to have regular discussions about his spiritual life with other clinicians on the unit, which I coached them through using this paradigm actually, and to have regular engagement with heartfelt prayer throughout the day. And sometimes he even prayed with me in session, which was atypical, but it helped him to engage. And Mike credited his remission from depression, which was not going well at first, to the spiritual engagement that he had, and so did his clinical team. When patients have spiritual struggles, I find that the way to help them, and this is what I encourage our clinicians to do at McLean, is simply by actively listening and reflecting what they are telling us and to validate their pain. When a patient says, I feel that God is punishing me, many clinicians have a tendency to say, no, God's not punishing you. And I can understand where that comes from, and I've wanted to say it myself in many cases. I don't think that's our role. I think that's overstepping actually in some ways. And what I prefer to do is to listen to the patient and say, it sounds like you feel that you're being unjustly punished. If I felt that way, I would feel just as, if not more, distressed than you. And to validate them and to hear them out. Often patients who come in with a spiritual struggle, they've never spoken about it with anyone. Many times they won't go to their clergy with their spiritual struggle because they feel ashamed or they feel guilty, and it's just too much for them and too intense. So I find that the best medicine in these cases is just to provide patients with a sounding board. By the way, if we put out the fire with cognitive restructuring, often they don't fully air the concern. A patient will untangle themselves often from a spiritual struggle if we listen to them and we give them space to do so. And that's what I did with Elizabeth Carmen. I sat there and I listened to her, and she got emotional. She was full of tears, talking about how her pain disorder was God punishing her because she grew up Catholic and she attended catechisms, and then when she went to college, she, fell off the wagon, as she put it, and she ended up marrying a man who had no interest in religion, and she felt that her pain was a punishment from God, and her opiates of dealing with that were a punishment, and her anxiety as well. And I just listened to her. I wasn't in a position to change her perspective on it or to challenge it. And we had very tear-filled consultations, and I provided her with just enough holding, so to speak, that she could self-regulate and come to a greater sense of peace with it. Finally, with spiritual symptoms, we provide psychoeducation. The two most important points are to say that the symptoms are not because of their faith, because when patients are blaming their faith for their symptoms, it can create a spiritual struggle. And hearing that the symptoms are not because of the faith can alleviate that struggle. So that's very important. Another piece of psychoeducation is that sometimes patients have spiritual symptoms and they can still have positive aspects of spirituality. Just because an OCD patient is compulsive doesn't mean that prayer or belief or religious study or connecting with other people in a faith system is bad for them. In fact, sometimes engaging in positive spirituality can provide a contrast, so that way the patient can see, oh, this is my faith and this is my disorder. And being able to demarcate where the spirituality ends and the disorder begins is part and parcel of their healing process in psychoeducation. Another point is that many patients have two of these effects, or sometimes all three. Sometimes clinicians make an error and think that the more a patient has spiritual resources, the less likely they have spiritual struggles. Empirically, they're actually positively correlated. The more a person has resources, the more likely they are to have struggles. And conversely, the more faith that a person has in their life, the more likely they are to have spiritual versus secular symptoms, like I mentioned before. So some patients have struggles and resources. Some have resources and symptoms, but no struggles. Some have symptoms and struggles and very few resources. So the importance is to look at these as disparate areas, although sometimes interconnected, and to assess for them independently. If you want to learn more about this approach, a little shameless self-plug, but my my editor and publisher asked me to do this. If you want to learn more about how to conceptualize or assess for and harness patient spiritual and religious life and treatment, this is a book that I published last year. It's out with Guilford Press. I'd like to take a minute, make a concluding remarks, and then I think we have some questions. We live in a very challenging area of history. A couple months ago, some colleagues of mine from the medical school published on a national survey of 65,000 college students. And what they found is that 20% had significant suicidal ideation. 9% of college students, not disordered college students, all college students, 165,000 students in 108 colleges had attempted to take their own lives, and that 25% or more were engaging in non-suicidal self-injury. So mental health, we are all very busy with what we do, but less than 50% of individuals with mental health disorders come to us for treatment. And the real shame is that we have solutions. We can help. We have amazing treatments, but the majority of people who suffer aren't coming inside. By contrast, spiritual and religious approaches to mental health have been going on for eons, and they're incredibly popular even to this day. Let me ask you, what's the most widely utilized mental health treatment on planet Earth today? Any guesses? The answer is 12-step programs, such as Alcoholics Anonymous, which are fully rooted in the belief in a higher power. That picture on your screen is the International Convention of Alcoholics Anonymous, which is so large they have to rent a football stadium. 60,000 people show up to that event every couple of years. And also, if you look at the last 20 years, why is cognitive and dialectical behavior therapy, why have they become so popular? Well, I wonder whether it's because of mindfulness, which is clearly based in Buddhist practice. For anybody who's done mindfulness, why is there a bell at the beginning? That is a vestige of temple worship in Buddhist tradition, clearly. And that has created a literal revolution in mental health care. Is there a medical center in the entire country that does not have mindfulness-based stress reduction somewhere in the medical center? I'd be interested to see if there was. Even in the secular, ostensibly secular age, people are seeking spiritual solutions to mental health crises, and that's because people have been doing this forever. So to say the least, I think it's high time that we get over our 100-year hang-up with spiritual and religious life, and we learn to assess for and address this domain of human existence just like we do anything else. Thank you very much.
All right, thank you so much, Dr. Rosmarin, for that wonderful presentation. We will now be answering any questions. Please submit all questions into the chat box. I believe I have a few. Can you hear me okay, Dr. Rosmarin?
I can hear you perfectly. I can't see any questions though.
Oh, perfect. That's okay. I'm going to say them out loud.
Okay.
All right. First question. Are you aware of Ralph Piedmont's Aspire assessment tool, which is another way of finding out about a client's spiritual religious beliefs?
Yeah, of course. Piedmont's done some great work. The problem is how underutilized Aspire is and other tools. There's really no shortage of psychometrically valid and reliable tools to assess 4 different facets of spiritual and religious life. It's actually amazing how many studies there are on different measurement tools. But the big problem is that they're so unpopular, especially among clinicians. In social psychology, you find it used a little bit more, but among clinicians, it's not. But the fact that whoever asked the question, the fact that you're familiar with it, that's definitely a good behavioral indicator for me.
All right, thank you so much. Our next question, is there research connecting religion with sense of community and the mental health benefits of that?
Yeah, sure. There definitely are community benefits. I glossed over it in the description, in the analysis of why spiritual and religious life might be a resource, because the majority of research looking at whether social factors mediate the positive effect of spirituality on mental health have shown that those are not primary mediating factors. So most of the mediating studies that I've looked at have seen that spiritual and religious life is more. And I guess a way to describe that phenomenologically is that when a patient connects with other people, it's good for their depression, good for their stress level, maybe even for anxiety. But connecting within a faith community not only is a interpersonal experience, it's also a spiritual experience. And I think that second dimension is qualitatively different, and apparently there's an empirical basis for that.
All right, thank you very much. We'll give participants a few more minutes to think of any other questions. We have one question. Do you think having a strong religious community could also negatively impact one's mental health?
Yeah, I mentioned that just as anything in life really can be positive, so too can it be negative. One of my religious mentors actually told me that. He said it very nicely. He said, anything in this world can be used for its purpose or for the opposite of its purpose. Rabbi Lawrence Kellerman from Jerusalem. And he pointed to nuclear energy, that if it goes unbridled, it can create incredible destruction. But if you focus it, it can destroy cancer cells and give a person a new lease on life. And religion's no different. Of course, being involved in certain faith communities can be very problematic, and I can give you tons of cases that has happened. But often those communities can provide support, meaning, purpose, comfort, and solace. So it's positive and negative like anything else in life.
Awesome, thank you. I think we have time for one more question. First of all, thank you for this presentation. My concern is that only clinicians who self-select with an interest in spirituality tend to attend these webinars. How do we spread the word amongst our non-religious/spiritual colleagues?
Amen, brother or sister. I have the same concern. I think ADAA is a great platform to be able to do this, and we are seeing, the hopeful sign I see is that there is more interest in mainstream academic and mainstream professional organizations and service organizations in this topic. And I am hopeful that there is a slow but an increased amount of interest, not only among the individuals in an echo chamber, but people who are in the general clinicians as well.
Awesome. All right. Thank you, everyone. And thank you, Dr. Rosmarin, for a wonderful presentation. Everyone will receive an email shortly that includes a link to the webinar evaluation, as well as a link to the recording of this webinar. For those seeking CE credit, the post-test assessment will be distributed after these few announcements, and the post-test assessment will also be included in the follow-up email for anyone interested in completing it at a later date. All right, thank you so much, Dr. Rosmarin. Have a wonderful day.
Bye.
This was our last ADA Live webinar for this spring, and we will resume our professional education program this fall. You can still earn CE and CE credit by taking advantage of our summer sale and also receiving 25% off all recorded webinars until August 31st. Use the promo code SUMMER25 at checkout to receive 25% off. If you are not yet an ADA member, we invite you to view the many membership benefits that ADA has to offer. Please visit ADA.org for more information. We'd also like to invite you to register for ADA's 2020 annual conference in San Antonio next year. And if you'd like to present, we encourage you to submit because our submissions portal is now open. On behalf of ADA and our presenter, we thank you so much for joining us today. You will now have the opportunity to complete the post-test assessment. You must have registered for this webinar with CE credit, obtain a minimum 80% or higher on the post-test assessment, and complete the webinar evaluation with the provided 4-letter code in order to be eligible for CE. If you did not receive a score of 80% or higher, please email webinars@ada.org to schedule a retake. I will now launch the post-test assessment. You may exit the training once complete.